I think the one great thing that UC Davis does that, to my knowledge, no other program in the country does, is we also have a component of sleep. So I teach a lecture to them, and we do a series of questionnaires regarding sleep apnea and the Pittsburgh screening questionnaire, which looks at just overall quality of sleep. The majority of patients with lung disease have horrible sleep. And we know that when they are sleep deprived, their ability to actually be able to exercise and function is markedly impaired. So we have identified probably about 50% of patients who come in that have sleep apnea that was not diagnosed. So we have a lot of overlap. And we'll wind up ordering sleep studies and treating their sleep apnea, which I think gives them a little bit extra bang for their buck. I gave a lecture to the regional meeting for pulmonary rehab, and we talked about this. And most of the programs are wanting to incorporate now a sleep component to that, where they start asking those questions, particularly if you have people who have CO2 retention and sleep apnea and they're not compliant with their CPAP machine and so forth, then we really need to work with them, because that has been definitely shown that it helps their quality of life and their daytime symptoms. So we want to put that part in also. That is a concept that a lot of people think, and a lot of patients think, well, I'm having oxygen, but your oxygen treats one part. If your airway closes up, you can't get oxygen through. So you may be on 4 liters at night and you really don't need it, because the airway's closed up, and until you open that, you're trying to force something down that's closed pipe. Putting them on positive pressure stents that airway open. They're able to actually get a real lung volume, which helps their breathing, helps their diaphragm, offloads the work of breathing, and they get better rest. They get better sleep. They have more ability to do activities the next day and exercise and have a better quality of life. Yeah, so a lot of the COPD patients, depending if they are CO2 retainers, we may use positive pressure, but it may be a different type of gadget. So it may deliver 2 different kinds of pressure, or it may deliver what we call an AVAP unit. So it's almost like a mini ventilator, in the sense that we tell it a tidal volume, and we can put a backup rate on it. It can do all sorts of things so that they actually can get better carbon dioxide exchange. Also, some patients have very different lung volumes compared to another type of disease. So depending on that, whether or not it's neuromuscular or whether or not it's emphysema, interstitial lung disease, it will be a very different strategy to oxygenate and ventilate them. Most of these folks have obstructive sleep apnea. There are some people who have heart disease with this who will have central sleep apnea, or if they have AFib, they may have central sleep apnea. So in that case, you do have to treat that differently, and it entails having to usually give them a supportive rate. So you just have to decide which way, based on their sleep study, is the best. But the biggest is that most of them would have obstructive sleep apnea before they would have central.